Manny's, July 25th, July 15th, 2025.
Awesome. Thank you. Thank you to the SF Standard for co-producing this with us. This is David from the SF Standard. Stand up, stand up. This is David. What a looker. He's the homelessness report of SF Standard. He's written a lot of articles. Thank you for doing this, David. You're going to hear a lot from him in a little bit. He's going to introduce our... talk about lookers. We're going to introduce our panel. This is day 2 of Understanding Homelessness. This is the second year we've done it. It was a big success, if you can call it a success, when we did it a few years ago. And the point of this week, thanks to Stacey Horner, Director of Programming, for making it happen, Stacey, is to give you all an understanding by the end of the week of this issue as deep as possible, so that you can take what you learned this week and tell your friends and tell your colleagues, because this is such an important issue in our city and it requires deep learning and understanding. So this is day 2. Before we get into the meat of tonight's, I'm Manny, nice to meet you, thank you for, and thanks to Esther and Louise for letting you in, and thanks to Anna for making you drinks, and Daniel for being our intern for the summer. Okay, before we start, who has a really juicy answer for what the best part of their day was? Does everyone have a good, because let's start with that. I asked you to introduce yourself to someone and say what was the best part of your day. Who wants to share what the best part of their day was? You? Yes? Oh, go ahead.
A friend of ours was in San Quentin for 26 years and he got out today.
Wow. A big nozzle for him. A big nozzle for him. What about you, Kunal?
What was the best?
You're in the middle, you're in the hot seat. What was the best part? What was the best part of your day? And you can't say being here at Manny's, don't pander.
I was actually not going to say that. No, we just passed our budget about 20 minutes ago.
That's pretty cool. Lots of big things happening right now. What about on this side of the room? Best part of your day? Come on, one last one. Yes, Daniel? What was the best part of your day?
I just met my brand new nephew on FaceTime.
Amazing. Mazel tov to your nephew. You ready?
I'm ready.
Let's do it.
Thank you, Manny. Thank you, everybody who works here at Manny's for putting on these events. It's an amazing space to hold these kind of important talks. This is an important moment in the city's history. We've elected a new mayor on his promises to reshape how San Francisco responds to homelessness. And we're lucky to have his point person on that issue, Kunal Modi, here. And we have Sharky Ladwana, member of the city's Homelessness Oversight Commission. They're going to help us understand what's changing, what's on the horizon, and how they hope to make the system work better. So thank you both for joining us. I want to start with you, Sharky. You've been a very active member of the city's Homeless Oversight Commission for the past couple of years, putting together an insightful video presentation that explains your thesis on why the system is failing people. I was thinking it would be helpful to have you start by telling us about that thesis, how that video came together, and what's the reaction been to it so far.
Great, thanks, David. So first of all, as David mentioned, I'm on the Homeless Oversight Commission. I'm in the seat for somebody that has experienced homelessness. So when I first moved to San Francisco at 21, I was a foster kid, pretty normal, actually fairly typical in the homeless population for foster youth to be homeless because you don't have the connections to parents as strong as say normal people do. As a result, I came here and I was sleeping under park benches, and then eventually I got a room in the Civic Center Hotel on 12th and Market, and I eventually got a job there. I worked there 5 years for the midnight shift, midnight to 8 a.m. And so this whole, everything about this area of policy has always been a pretty interesting thing for me. However, prior to the Homeless Commission, I was actually on the Small Business Commission. I'm a small business owner, and I was the president of that commission all the way through the pandemic. And then after that ended, I said to the mayor, okay, I'm done with the Small Business Commission. And she said, well, is there any way we can get you to stay? I said, no. I'd like to do something harder. And she said, what? And I said, I'd like to be on this new homeless oversight commission. She said, well, I'll think about it. And so I had to kind of grind on her, and eventually I got on it. So when I got on this commission, something that I was immediately very curious about was, even going back to when I was homeless in the early 90s, what I had always, what had been a constant throughout all the different interventions and policies that we tried to improve homelessness, it seemed like the population of homelessness was always stable. It hovered around 8,000 people, 4,000 unsheltered, 4,000 basically couch surfing or, you know, in some kind of other interim housing. And so I thought, well, geez, you know, now that I was on this commission, I could see the budget was just zooming up over a period of many years, but the population was very stable. So I wanted to understand what's going on here. You would think, looking at 8,000 people, well, okay, just get 8,000 shelters or 8,000 homes, put them into homes, problem solved. You know, our work is done here, we can move on. Of course, the reality is it's not the same 8,000 people from day to day. So if you can think of it like a pipe. So if you imagine like water flowing through a pipe, and you take a snapshot of the middle of the pipe, and you say, okay, there's 8,000 people inside that pipe. So you take that section of the pipe out, you put it over here, you put it in housing. What happens to the pipe now? Well, it just fills up again. And now you got another 8,000 people. So you take that out and you put it up here, and then another 8,000 people come. And it fills up, and it just keeps filling up. So then I started to wonder, well, how many people are we serving, actually? How many people are coming in? We need to know something about the throughput, the flow rate. How many people are coming in, and how many people are going out? And when I first asked that question to the HSH, it was like, well, we don't really know. I was like, well, geez, that's peculiar. Why don't we know? As well, the data exists on different tables. And I said, well, you know, we should be able to, I write software for my company, and I said, I think there's a way that we can figure this out. So we worked and collaborated together, and over a period of a couple months, we were able to get to the bottom of this, which is how many people are coming in and how many people are going out. And when I say going out, I want to delineate here. There is, in this realm of policy, we talk about homeless exit. So when we say somebody has exited from homelessness, they have exited from being homeless to now being in a home, in shelter. But that doesn't mean that they've exited from our services. So we can still be providing them services. We can still be providing subsidies for their homes or housing or services, mental health services, physical health services. It's a long list of things. But obviously, as long as we're providing services, there's not an infinite amount of money. So as long as we're providing services, this means that that is that much less services to help people that are coming in. So I felt it was really important to understand how many people have actually left, meaning we're not providing them any more services, and how many people are coming in. And it's important to understand because when people completely leave the system, when they graduate, hopefully in a positive way, right? Like they become self-sustaining. That's the goal. The goal is to help people be able to provide for themselves. So to the extent that we can know that number, that's what tells us how healthy the system is, right? If you can imagine a pipe, if one person's coming in and one person's going out at the same speed, then what that tells you is that's a healthy, sustainable system. We have people going in, we have people going out. What we found through doing this research is the number of people going in, what we call the inflow, was increasing. The number of people going out was also increasing. But the problem was the people going in was increasing much faster than the people going out, almost 3 to 1. So the challenge then becomes, okay, what do you do? Like, you got more water going into a pipe than is going out. Well, there's something you could do. You can increase the size of the pipe, right? Then you can hold more water. And that's effectively what we've been doing. We've been putting more and more money to make the pipe bigger so that we can hold more and more people. And as I sit here today, we currently, most of the homeless supportive housing's budget is actually spent on people that have housing. It's not on the homeless part. Most of the money goes to housing people that were formerly homeless, about 62% of our budget. We have 15,000 people in permanent supportive housing. And these are, I should say, we get money from the state government, we get money from the federal government. There are partners in, it's not all on us. But, importantly, if we keep on this path of more people coming in at a faster rate than people going out, well, sooner or later you run out of money. It doesn't increase infinitely forever. And that is exactly the moment that we've arrived. This most recent budget, we were dealing with 800 million is where it initially started deficit. The mayor is required by law to balance the budget. Required by law. It's not optional. So before we were able to get around it by borrowing money from reserve funds and this and that. We've kind of run out of all those get out of jail, I wouldn't say free, but we've gotten, we've run out of these little magical ways to move the budget around so that we can pay for it. So now we actually have to make things work. And then on top of that, we're almost done. And on top of that, we're now dealing with an outside externality, which is very challenging, which is the current administration in the federal government is clearly and obviously not inclined to continue to provide money at the rate that they've been providing it to us in the past, let alone increase, which is what we would need in order to keep going on the path that we were going on. So where this all leads to is, once you get this idea that you're looking at a number of 8,000, right? I mentioned this number 8,000. But really, the number of people flowing through the pipe any given year is closer to 20,000, right? That 8,000 is just a snapshot. So now, the challenges, the fundamental challenges, we know we're going to have less money. We have challenges downtown with our downtown economy. That's where all our tax revenue comes from. We have challenges with the state. The state has changed how much money they want to allocate to this issue. We have challenges with the federal government. So where this all leads us is, if we want to continue to provide the same level of services that we're continuing to provide, and if we want to actually increase the effectiveness of the services that we're providing, then it is incumbent upon us to figure out as many different ways as possible to be as efficient as possible in increasing what we call flow, which is just optimizing for keeping people moving through the system, helping them. You don't want them to get stuck in one part of the system, if at all possible. Sometimes it's not up to us, it's up to them. But you want to help people move through the system, and by helping people move through the system, we actually create more capacity to help people that need help that are not yet in the system. And that's where we sit today.
Thank you. That was great.
I was very lucky to have Sharkey to consult with well before the transition, but during the transition. And I tell everyone, whenever they ask, like, help me understand, what's going on with homelessness, I refer them to Sharkey's video. So if you haven't seen it, you got the live version, but I'd encourage you to still go back and watch it. So I'll take on, well, let me just zoom out a little bit. The mayor's kind of articulated 3 big priorities for our city. The first is tackling public safety and behavioral health crisis. The second is economic recovery, and the third is accountability and transparency of government. The reason the behavioral health and public safety crisis is so critical is not just because we want to support those who are struggling on our streets. It's the right thing to do. It's the San Francisco thing to do. But it is so vital to our economic recovery. 40% of our tax revenue comes from downtown. Creating the conditions for a safe and thriving downtown or commercial corridors is existential to our economic recovery as a city. And we know, government accountability and transparency matters more than ever in this time of a budget crisis, because we have to make sure we have good fiscal stewardship in a federal climate that won't be friendly to San Francisco. So that's why, tackling this crisis is so critical, beyond it being probably the top thing that's on everyone's mind, which is why you're all here. When we take Sharky's proverbial pipe analogy, the question we ask ourselves is, why are people stuck? Why are people not getting through there? And so we started with the inflow. And one of the first things we had to really understand was, what problem are we trying to solve? There are multiple problems you can solve, and we talk a lot about homelessness in this city, but we, I think, all mean slightly different things. There are 3 different problems we're trying to solve. First is those folks who are truly homeless, genuinely unhoused, and that is a thing that will end their homelessness. Second cohort for whom they're struggling through a behavioral health crisis, psychosis, PTSD, the full spectrum of different crises you could be challenging with that have accelerated post-COVID. And third, a drug addiction crisis, highly intersected with fentanyl, particularly post-COVID. And many of whom fall in 2 or 3 of those camps at once. And so what we saw in this kind of the modern homelessness response system that we know of today began over 2 decades ago. At that time, the hard drugs were, every generation has had its hard drugs, but they were not as hard and they were different. There was a lot of alcoholism, and we were dealing with post-industrial job loss. Today, we have a situation where 51% of people, this is self-reported, so a lot of our experts think it's higher, struggle with serious mental illness or a drug addiction, principally fentanyl. And so we have a very different level of acuity. And so we had this kind of changing nature of the inflow, but we had been developing a response system that looked a lot like the needs of kind of what was existent 2 decades ago. And so when you look at that pipe, just to put some dimensions around it, the first thing when we did when we came into office was we asked, well, can we get an accounting of every bed and slot that San Francisco funds today towards this crisis? Because Sharkey named sort of Department of Homeless and Supportive Housing, but they're not the only ones who play a part in this. This is the Department of Public Health, the Adult Probation Department, the Mayor's Office of Housing and Community Development. And as we did that work to understand over the first 3-4 months, what is our system today, we found it's over 20,000 beds and over $1 billion annually of funding. And those 20,000 plus beds are about 13,000 in permanent supportive housing, and I think we'll unpack each of these different things throughout the night. 4,300 in kind of low barrier emergency shelter, 2,600 in behavioral health, and then a mix of different transitional housing and subsidy programs. And so what we found was people who have increasing levels of clinical acuity of drug addiction or serious mental illness, either entering a shelter system where, there may be 8 hours of one nurse or clinician on site per week, or entering a permanent supportive housing unit where maybe what they need is actually care that looks more like a skilled nursing facility. But entering these formats where they're not getting the type of clinical supports and care that they need to actually break through their behavioral health crisis or addiction. And so they're stuck because we're not getting to that side of self-sufficiency. And so what you have is growing need, not as many people moving through the system. There are people graduating through the system. We have been putting more money towards the crisis over the past several years. But if we kept doing the same thing that we were doing, we could spend another $1 billion per year and we wouldn't solve this crisis. So, especially in a time of federal uncertainty, and state, frankly, budget uncertainty. A third of the homelessness budget comes from federal and state sources. We have to think very differently. And so that has been the work that we're doing, and I know we'll get into it, David, of how, at a high level, how do we get our homeless response system to be much more deeply integrated with our behavioral health care and healthcare system, and have this system of care operate more like a professional health system, so that we are actually helping to get people through the system to the other side of self-sufficiency. That'll take a lot of different strategies. It'll take also closer partnership between not only health services and social services, but with our paramedics, with our law enforcement. So you have to kind of bring all the different components together, because we are both trying to tackle drug addiction, behavioral health, and homelessness in one. And so that's partly what we've endeavored to do. That's what we put forward through our budget proposal. That's what we're trying to do with our street teams. I know we'll get into all that, but that's the principal challenge we're trying to solve.
Thank you. It's interesting because when you describe the pipe, and you describe, all these people coming in, people not coming out maybe at the same rate that they're coming in, I think most people would point to prevention and say we need to stop people from coming in. I'm interested, Sharkey, your thoughts on whether that is the approach that the city should take, and can you explain how that fits into your model? Because I heard you guys talk about trying to get people out the other side of the pipe and to graduate into independent living. I'm curious, does one might come at the expense of the other, or where against it?
Yeah, that's a great question. So, the two opportunities, the two real big opportunities are prevention, decreasing the inflow, and that's the prevention aspect, and increasing the outflow. And they both have a lot of inherent challenges. But on the prevention side, one of the biggest challenges is it's almost like Minority Report, where you're trying to guess the future of somebody. Or me, I'm in small business. If you ask any small business person, when you spend money on advertising, what worked? And they say, well, there's an old saw about this. I know 50% of the money worked. The problem is I don't know which 50% of the money worked. So that's, I think, one of the challenges in looking at the prevention side, which is, that some people, looking at a cohort of people that are likely or at risk of becoming homeless, some of them are going to become homeless. Some of them will not become homeless. Even if you hadn't done anything, they would have figured it out on their own. So the challenge when you're administering city dollars, city tax dollars, is how do you make those investments? And then how do you understand whether those investments were effective at preventing what it was that you're trying to prevent? And then, how do you measure the success and make sure that you're being as efficient as possible of how you allocate those city dollars? The second part of it, and this is something that I've worked with my friend Chris Beam over there. Knowles knows him really well too, the gentleman in the beard. He's actually one of the brightest people on this subject.
Ann is here too, our colleague.
Oh, fun. Oh yeah, there you are. You're way back there. Yeah. Okay, yeah, so the three of us have had little think tank chit chats about how we might try and make some of this stuff work better. The part that I think is particularly interesting for us from a prevention standpoint is immediately after somebody becomes homeless, well, now you're not guessing whether it's the 50% that's going to be homeless or not be homeless. Now it objectively, definitively is. They become homeless. So here's what's really interesting and what I think is one of the really big opportunities for the city. So we know scientifically, like this is well documented in academia and research, we know that if we can intervene when somebody immediately after they become homeless, we know we have this massive, huge opportunity to stop a progression to what we call chronicity, being chronically homeless, because every day that somebody is on the street, and in every single demographic, children, teenagers, adults, senior citizens, every single racial demographic, every single social demographic. Every day somebody is on the street, their risk of negative health outcomes shoots up exponentially, just almost by day. You can chart it by day. Risk of drug abuse, risk of substance addiction, risk of health outcomes, risk of trauma, mental health issues. It's interesting because some of these issues are perceived to be as a cause of homelessness, but they are also a consequence of of becoming homeless. So the prevention part is very, very interesting, and what I've been trying to encourage the department to do, to get to the meat of your question. I've said this in hearings before, and some of this is really relying on some of our outside providers, because so many of our services are provided by nonprofits, not actually by the city itself. But I said, could you please, when you're engaging in prevention, could you identify the people you want to help? We know you can't help everybody, but identify everybody you would want to help, and then track them all. Track the ones you helped, track the ones you didn't help. So in science, that's called a randomized controlled trial. And that is how you determine which interventions, which things you did actually had a positive effect and delivered the outcome that you're hoping to seek. And so that's what we're chasing after, and it's big and it's complicated, and there's all these different nonprofits and there's budgets, and it's very thousands of people just trying to organize them and get them mentally centered around this is incredibly challenged. That's the work this guy's doing.
Just pick up on a couple things Shark said on prevention. So first of all, this is, if I'm breaking news, San Francisco is not very affordable, so that's obvious to all of us. So this work obviously exists within the context of all the work that we're doing around affordable housing. So the mayor introduced a family zoning plan that creates the capacity to increase over 46,000 new affordable housing units here in San Francisco. That work is critical and runs in parallel to all of this, because I'd be remiss if I talked about prevention without talking about more affordable housing. But more acutely, we are, one of the first things we did with the Breaking the Cycle work is to get more investments into prevention, like actual upstream subsidies for those who are extremely low income at risk of homelessness. Emergency cash assistance and rental assistance is a real tool in our toolkit that could work a lot better and be a lot more data driven. There's other counties across the country that have used data signals to help get cash assistance to people who are on the margin, because there are a lot of families in San Francisco for whom that unexpected car breakdown or medical payment is the thing that causes you to fall behind on rent and subsequently become homeless. So we can get a lot more mileage from our emergency assistance programs if we take a more data-driven lens. So that's absolutely something we want to do. The Department of Homeless Supportive Housing, over 60% of its budget really goes to funding those 13,000 units of permanent supportive housing, over $400 million a year. And so, but we spend very little on prevention. And so we need to think about our balance of our portfolio to focus on more upstream solutions. And then to Sharky's point, those first 48 hours really matter. Really, really matter. In our family homelessness system, what we find in our shelters is fascinating. 48% of people resolve their homelessness within the first 90 days. Then the next 90 days, 90 to 180 is 16%. 180 to 270 is another 14%, and then 21% 270 onwards. And so if you can pull more of those folks forward because you get the right interventions earlier to help them get a path to stability, it's not only a much better and human outcome for those families, but it's way also financially prudent for the city. And the reality is no one gets better the longer they're on the street. And so getting up front matters. And then I will say, this is probably a little bit of a third rail to mention, but we do have to talk about inflow out of county. San Francisco is 20% of the Bay Area population, 28% of the shelter capacity, 40% of the permanent supportive housing capacity. So we have done a lot in our county compared to other counties around us around building housing inventory. our neighboring counties haven't always done as much, and so it is true that we, in some senses, serve as a bit of a services hub for the region. I think it's a public conversation we should have. I think we have our values. There's someone on the street, we want to make sure they get care and 3 square meals, but we have to think about how sustainable it is for us to have that obligation in perpetuity, and to think about how are we making sure we're really serving San Franciscans in need and helping them get to a path on stability, and how are we helping push our regional partners to build inventory as well, because we cannot solve this alone in San Francisco. We need to do this as a Bay Area region. We frankly need to do this across the state in California. Most of who we serve is from California, and so the state has been pushing counties across the state to build more interim housing inventory like San Francisco has done, and so we're also going to be, I think, proponents in Sacramento to push other counties to do their part as well.
Thank you both for that. It's interesting to hear you talk about the first 48 hours, because historically, the way our system has worked is it prioritizes people who've spent the longest on the
Yes.
streets and the most desperate and sick, and you know, I don't know if there's a correct way to do that prioritization process, and I don't want to get us too off the rails on that. Probably a discussion for another time.
There is, and we could do a whole night on coordinated entry, yes.
Well, let's do that. I want to get back to the 20,000 beds. I'm really glad that you did that assessment, because that's something I've asked of the city before, is how many beds do we have? Where are they?
I should write for the Standard.
Well, you have actually, you asked me to get I've heard something that's come out of this administration a lot is we need the right types of beds.
Yeah.
I'm curious, you know, does that mean that we have the wrong type of beds currently? What do we do with those beds that we don't deem to be, you know, working for people? Is that, am I correct in that assessment, that there are beds that aren't the right kind of beds? And what do we do with the people there? And, you know, 20,000 beds, $1 billion. Can you talk a little bit about your thought process on reshaping that part of the pipe?
Absolutely. This is going to be the lion's share of the work that we do in the coming months and years. And so, again, I think a first critical step over the past 6 months was developing that baseline of every bed and slot and having that visibility into the portfolio that we have today. And step one for us after we developed that baseline was we absolutely need to add the right beds to address those most in crisis on our streets today. So those priorities have been the first 48 hours of crisis stabilization. We opened the center at 822 Geary with a very high clinician to patient ratio to be able to serve those who are most in crisis. 14-day drug treatment, where in exchange for a shelter bed, you agree voluntarily to start a drug treatment program so we can get folks in the grips of fentanyl addiction started on a regimen of buprenorphine or methadone so they can start to break that addiction, and making more clinical investments in our existing in our existing system of care. So that was step one. There was other gaps in our system, like we had no sober housing in our portfolio, we didn't have good residential treatment off-ramps. So we've been very focused over the past 6 months. We've added over 400 beds. We, in our budget proposal, have another 1,000 budgeted that will come online through the course of the next year. Step two, step two is now how do we start to reshape the existing portfolio of beds that we have in our ecosystem. And so we're going to start to convert some of those beds by adding more clinical services so that folks who are in permanent supportive housing and who may really need care that looks more like a board and care or skilled nursing facility get that level of treatment. And so we're going to try and scale that 14-day drug treatment program to more of our beds. We're going to try and make some of our shelters more clinically intensive. So there's a whole conversion aspect. And then we're also investing in off-ramps, because there's also, this is a data-driven point that we are hunting down and doing our own assessment of those 13,000 people who live in permanent supportive housing. We estimate anywhere from 15 to 20%, maybe with the right housing subsidy, like a permanent supportive housing unit costs about $40,000 to $50,000 per person per year. There are some people who are working in those units and could afford, they're priced out of the private market, but if they had $1,000 a month subsidy, could actually move out of permanent supportive housing, because they don't need the support services, they're just economically not being able to meet that rent obligation. And so $1,000 housing subsidy is a $12,000 a year annual expense relative to that $50,000. It's the right outcome for that person too, because they get to sustainable housing. And so what we're trying to do is, again, get that right, the right beds, convert the existing beds, and create those off-ramps, and we may selectively divest beds if we can increase the flow. As Sharkey said, the reason we've been pouring so much money on this over the past several of years is to just increase the size of the pipe. If we can increase throughput, we can actually modestly even decrease the size of the pipe and just operationally continue to serve the same number of people. So that's a big challenge. That's what we're gonna work through over the next couple of years, but that's the strategy that we're working towards.
Sharkey, anything to add?
Yeah, I'd just say that when systems are efficient, sometimes it's not even you're going to serve the same level of people. You can actually serve more, and you can help more people. And so really, I think that's what we're chasing after here. I mean, if we're spending $45,000 on somebody who really just needs $12,000 of assistance, well, that's just one person. That's 30,000 people. If we're talking, or $30,000. If we're talking, there is potentially 2,000 people. Now we're talking $60 million. So that's a lot of money that could help a lot of other people. So getting these dials and levers dialed in right, and one of the things I really appreciate about Canal and how the administration is approaching this, and I think I can say this with some level of neutrality because I was appointed by the previous administration. But one of the things I really appreciate is the focus on data and data-driven approaches. Because when, I say this as a small business owner, there is a tendency, both in the city and in businesses and among your employees, you want to focus on the process. You want to focus on the methods. No. You need to focus on the results. You need to focus on the results. And it's data that tells you this is what works. It's empirical. It either worked or it didn't work. And if you focus on what works and keep building on that, you're going to get better results.
We have time for one more question, and then we'll open up the audience. Unless you get something
Just
really
one
quick.
quick thing I want to say, because we're all sitting here at Manny's, we're talking about systems and data. I just want to humanize this for a second. There was someone struggling. We've probably seen them in the Mission or in the TL or anywhere in the city. There was an individual who had been to the ER 104 times over the past 2.5 years. 104 times, whether 5150 hold, discharged, going through a shelter, all of that, right? That is unbelievable. And it is not just a moral failure on our part as a state, it is unbelievably tragic. There is nothing progressive or kind about letting someone struggle on the streets through that kind of crisis, in and out of ERs and jails and all that. There's nothing kind about that. And so this process to be really granular around how do we solve it for that person? Because that is the thing we haven't been doing a lot as a city. We've been focusing a lot on housing for people who are formerly homeless, which is important, but we're trying to the folks who are most in crisis on our streets, how do we be laser focused on what are actually the clinically intensive supports they need, and how do we get to them? That's all our way that we've reformed our street teams to bring different capabilities. So we met that person. That person finally is now sheltered at Gerald Commons in the Bayview. That shelter is a joint operation between not only homelessness and supportive housing, but Department of Public Health and Department of Disability and Aging Services. And so now our challenge is how do we scale that? But that that's success for that person. That's what we're after. And we're trying to do that at scale through all the system design work. But I just want to not get lost in the systems and data and bring it back to that person.
That brings it home, for sure. Do we have time for one more question, or do we need to?
A baby one.
You got lucky. Just kidding. But yeah, I mean, we talked about evaluating what works and what doesn't. You know, last week it came out that, you know, you're not focused on building this 1,500 shelter bed goal that Daniel Lurie had campaigned on. You know, I wanted to ask you, if we aren't aiming for a certain amount of beds, how will you evaluate success, you know, over the next 6 months, a year, 2 years, 3 years?
So the kind of high level answer is we will all, like, it is that every family can walk down any street in San Francisco and feel like they're not seeing folks in crisis on our streets, because it's not good for those people and it's not good for our families. But of course, underneath that is a whole lot of data and, you know, things that we're looking at. The data in the homelessness space is really bad, actually. The way all these numbers that we're citing, they're from like a once every 2 year point in time count that's very crudely done. And so we look at a lot of different signals. We will look at the point in time count and what the unsheltered and sheltered numbers are doing, although we don't look too closely because they're kind of crude measurements. We will look at our tent counts, which in our most recent count a few weeks ago was at its lowest level since the tent count began in 2019, so that's one signal. It's not in and of itself, you know, pure success, but it's a signal. And then we're gonna look a lot at inflow to outflow ratio. And we're gonna look a lot at, like, again, I think about it a lot like a health system looks at. They look at length of stay, they look at time to transition between formats, they look at successful patient outcomes. And so I think a distinction is we're taking a whole ownership mindset over individuals who enter our system of care, thinking about how long and do they get the right interventions while they're in our system of care, and do we ultimately graduate more folks out and flip that ratio that Sharky was talking about. So those are the metrics we'll look at to help us understand whether we're on the right track, and if we're not, we'll make changes. And as you referenced, like, we're not gonna be worried about any kind of particular political objective. We're just really trying to get more outflow than inflow, and to serve as many people and to make sure we get as many folks who've been cycling in and out of EDs or jails into the care that we want for them.
That's helpful, thank you. Opening up the questions now?
Is that all right with you?
That's great,
So,
yeah.
what we're gonna do is, you can choose, and then we'll give them the wireless.
I think she had her hand up before even.
So I think you said it was 20,000 beds and $1 billion. Is that correct? Okay, so I guess the process and the data is all really great, but like the cost driver, like what are the primary cost drivers behind those things? And are you all also trying to lower the total cost? Like, it seems crazy to me that one person would cost $50,000 or $60,000 a year to have in the temporary housing.
Yeah, yes, we absolutely are looking at not only how our system can operate more effectively, but more efficiently as well. Two parts of it is, how do we actually, in some cases, we're gonna have to increase the cost of service provision so that we can meet those more clinically intensive needs. Some of our costs stem from actually, when you provide the wrong level of care and the consequences of that, it can end up being more costly. In other cases, we'll need to lower our amount of support because we're serving a more economically homeless, we don't need to, so we're gonna have to do that work to optimize the amount of spend per bed format by actual patient need. Another part of it is actually our sources strategy. We have been funding all of this work principally, again, 2/3 of it from our local general fund and funds from our dedicated tax around at Prop C. A lot of what we're talking about here is healthcare delivery services, and we have not historically done a good job of building a Medicaid billing infrastructure for what is really healthcare delivery functions. And even in the light of all the federal stuff going on, a lot of those core Medicaid services continue to be available to us. So we are exploring building a billing hub within our Department of Public Health. like, San Francisco's got a truly unique opportunity. We're a city and a county, and that's a really big deal, because the county healthcare system is within our governance. We have a $2 billion county health system, right? The General Hospital, Laguna Honda, 15 primary care clinics, 55 specialty clinics. The San Francisco Health Plan, which is our managed care plan for the county, has 90% share of Medi-Cal enrollees. We have Kaiser-like vertically integrated dynamics, but we don't act like it with our homeless response system. We kind of think of it over here. We have to think of it more like our health system. And in this time of budget crisis, be smarter around how we're working with Medi-Cal. And so our new Department of Public Health leader is phenomenal. He was President Biden's Medicaid director. We're very lucky to have recruited him here to San Francisco. And we've spent time in Sacramento working with the Medicaid director, Secretary of HHS at the state level around how do we build that infrastructure. There's also other state reforms through Prop 1 and other things I won't get into, but we're gonna be smarter around the non-local sources of revenue to fund this work in the future.
Can I there's a question you're getting to, which I get a lot. And it's like, why does it cost so much? And that's the question I get all the time. And I think that needs like a little bit of light shed on it. So for a shelter, we spend something like $60,000 to $70,000 per year annualized per person. For permanent supportive housing, that's cheaper. It's like $40,000 to $50,000 annualized. You may have seen tiny homes online. Those are actually insanely expensive for the city. They cost $70,000 to $80,000 annualized. One of the most expensive things we did was tents. Tents cost us $68,000 annualized per person. So I get it. You know, this person's like, what the fuck? What are you fucking talking about? Yes. So this is really important for people to understand. It is not the cost of the structure. That is not where the money is going. It is all the things. The jargon in homeless policy is wraparound. That's what they call it. It's literally all the stuff that wraps around the people. So starting with, you show up at the place, there's somebody there to check you in. That person costs money. There's somebody there to show you where your bed is. There's people that gotta change the sheets, they gotta do the laundry, they gotta bring the food, there's security, there's people that gotta do janitorial, there's paperwork, there's all this like, you know, multitude of things that are happening. And this is before we even get into providing mental health care, physical health care, having a nurse on staff that's incredibly expensive. So all these costs stack up. So when you look at this and you're like, and then when we get to tents, why are tents so expensive? Well, it turns out we have to bring in power, we have to bring in water because we have federal and state standards that we have to adhere to. And bringing in power to an offsite facility, bringing in water to an offsite facility, bringing in plumbing, toilet, so that it's not third world conditions. All of that stuff, it all adds up and it becomes insanely expensive. And so that's why. If you ever wondered, why does it cost so much? That's why.
So David, before you ask the next person to answer the question, I would love for the esteemed panelists to perhaps try to shorten their answers so we can get to more questions from the audience.
I couldn't say it, so. I think I saw you with your hand up.
I got you, maybe.
I was wondering if there are other cities that you're looking to, like we all talk about this, like San Francisco is on its own and the whole country for all these decades has been working on this issue. I know Houston is noted as having had a significant decrease. So I was just wondering if you're collaborating or drawing on successes in other cities.
Yes, we are, but I'll expound it. We have talked to our counterparts in Houston. What they do particularly well is help convene a very diffuse provider network to all row in the same direction, which we have a lot of fragmentation and a lot of nonprofit service provision here. And so we're taking lessons learned from them around how do we do that with greater consistency and accountability. There are some things to learn from Boston around how they've integrated healthcare services. They've had some things that they've had challenges with too, so we're watching that. There's Hennepin County in Minnesota that has done some interesting stuff. So we are And then we're learning from things that haven't worked in other jurisdictions as well. We're watching what happens with our regional counterparts. So we talk to Santa Clara and San Mateo and Alameda frequently. So the short answer is yes. We are looking at other counties. We don't have to do the thing that we too often do in San Francisco, which is think we have to invent this from scratch here. There's a lot that we can learn in other jurisdictions that have cracked the code on some of this.
Let's get in the back over there.
Sharky, at the beginning of your talk, you mentioned that you had to run around for 2 or 3 months and to gather data to figure out what was going on. Kunal, you mentioned that the point in time counts could be, that data can be somewhat spotty. What efforts are being made at a more structural data infrastructure level to sort of more efficiently pull data from the different sources that are involved and to sort of unify that so you have some analytics around what are we doing, what works, what doesn't work, and you don't have to run around and sort of patch it together every couple of months?
It's gonna be hard for us to brief on this. Sharky's done incredible work before we even arrived on the scene trying to build a more data-driven infrastructure through his role on the Oversight Commission. We're actually spending a lot of time with our Department of Technology, Data SF colleagues on how we think about better data interoperability across our departments. We launched an RFI. We had many of our notable technology partners across the city respond to it around how we can better use data and technology to support our street teams' operations. Basically, at the end of the day, the challenge is each of our departments is on a different system of record. So we have Epic for our healthcare system, but our behavioral healthcare system is on a different homegrown platform called Avatar. Our Department of Homeless Supportive Housing uses something called the One System. It's not on Salesforce. It's on a company called BitFocus, and so our Department of Emergency Management, different system. Same with through our street crisis response team, through the fire department. Same with the police, and so we have built sort of a V1 as a city called Astrid, which is Supervisor Stephen Sherrill was actually the champion of this when he was at the Mayor's Office of Innovation, and we've been building upon that with his partnership to at least create kind of the API layer so we can start to talk across our different systems and be more flexible. Part of the reason it's so hard for when you query the Department of Homelessness on like their data, it's like this data dumps into a looker table that's really hard. Like there's like one person who can write the query, and so we just need to. This is not how we can run a modern enterprise in 2025, and so we're thinking as we do all the really important human work on the street operationally and in our shelters and permanent supportive housing, we're also focusing as much, and this is that government transparency and accountability of like the systems and infrastructure so that we can do this work smarter in the future.
And I'll just add to that briefly that the city also has to be very mindful of HIPAA, which is people's privacy. And at the end of the day, particularly on this subject, we're talking about health records, we're talking about personal records, and actually getting that data from one system to another. There's a lot of regulations that govern that, and that's just another complexifying factor.
Second row right here.
Hey there. I am a supervisor over at the General Hospital, and I work with the high utilizers.
Yes. Okay.
The super users.
Yes.
So, you know, not just 100 ED visits, but up to 1,000 a year. What we've noticed recently since January, a few things. One, in regards to discharge shelter beds. In the whole general hospital, sometimes we're allocated one shelter bed for all of the hospital. And then we have patients come to our clinic on the outpatient basis. They're trying to get shelter beds, and we'll put them on the list, and it'll be a week, or it'll be 2 weeks. And then when their name is finally called, they'll have a 2-hour time frame. They'll have to call between 10 a.m. and noon. It used to be 8 to 10, but they recently changed it, or maybe it's 12 to 2. But anyways, it's 2 hours that these folks who are highly disorganized, many of whom are using substances, have to present in one place.
and that's the only way they can access shelter beds. So a few things, we've actually noticed a decrease in our access to shelter beds in the hospital setting since the new administration. And you know, these are from acute medical settings. So one, is there conversation about this? Is there a way that we can, you know, make it more feasible for folks of high acuity to get shelter beds? And what's the conversation look like so far?
You're absolutely right. I don't know about the decrease, but the fact that this is a massive problem that we need to solve. We are in the process of redoing our bed allocation processes so that it's much better matched to people's need and not just on chronicity, as David mentioned. I don't know if you've heard this term of 5150 hold. It's kind of probably become too popular in San Francisco, which is a sad state of affairs, but it is when someone is unable to care for themselves, involuntary hold, and oftentimes, and you have to meet a standard of grave disability, and people are often brought to the emergency room or psych emergency services. And even though it's a 72-hour hold, the challenge is people typically only meet that standard for about 20 hours. And then you try and discharge them, but then you're like, well, I don't know where to send them next. So oftentimes they end up back on the street, which is terrible,
Or back
tragic.
in the emergency
Or
room
back
for
in the emergency room.
$8,000 a day.
Yeah, or $8,000 a day.
Wow.
So we're in the process right now of converting some of our shelter sites to be specifically dedicated for post-discharge from ERs and post-emergency services, psych emergency services. The way we look at it, after 5150 hold, we have to start a shot clock of 20 hours. And we have to make sure that when someone is discharged from your care, that they have the next best place to go to. And so we're going through that process right now to ring fence a number of beds that will be informed by the needs. And I know our Department of Public Health has been working closely with folks at the General and PES and our other partners, CPMC, to make sure we have that right capacity. But this is critical to flow.
Time for one more?
Yeah, we could have time for one or two more. It's moderator's choice.
Let's go right next door there.
When the Baldwin became PSH maybe 8 years ago, it was really unpopular. Nobody wanted to go there because there was no private bathrooms. And then when they converted it to shelter again, it was one of the most popular placements because it was non-congregate. Are you looking at doing that for more underutilized PSH sites?
We're gonna look bed by bed through the portfolio and think about how do we put that resource to the best and highest use. And sometimes that's increasing services, sometimes that's converting it to a different programmatic model. And we are very focused, again, I don't say this to sound draconian, we've been very focused on what people want. We're asking sort of a different question. We're focused on what do people need to break the cycles of behavioral health crisis or drug addiction or homelessness. And so that is our goal. We know those dynamics. One of the things we measured was in a triage center we set up at 6th Street. David, you'll remember this because we talked about it. We looked at placement rates by format, and what you found is placement into non-congregate is much higher than congregate. So we have to be mindful of those dynamics because this is as much about building trust with someone and helping them, get into the care that can help them get better for those cases that are voluntary, and of course making the decision for folks when we can give them kind of the more clinically intensive support that they actually need.
One more? Let's go to the corner right here.
Which one?
Get it back.
The final. Thanks.
So, Sharky, you mentioned RCTs, and both of you have talked a lot about metrics and evaluation, and something that I was wondering about was, are you worried about the potential of overfitting on these metrics and overlooking interventions that are hard to measure? I'm particularly interested about how are we actually measuring these wraparound services, and can we really identify causality in the way that I think we all hope to have, but we can't really oftentimes.
I think we have a long ways to go before we're in danger of overfitting, first of all. I think we're dramatically underfitting. We have a significant shortage of data just across the board. And we also, as Kunal was explaining, we have a lack of consistency of data on top of that. So not only do we not have much data, but the data that we have isn't always collected in the same way, doesn't always mean the same thing. It's very fuzzy, as they say. I think that's a problem I would like to have. And I hope to get there. It's my goal to get to a place where we're overcorrecting. But your point about causality, so I think that this is something, Kunal talked about this at the very beginning, and I think this is an important point to make at the end of this. What are the causes of homelessness? Well, the single most highest correlating point of causation of homelessness is the cost of housing. So this is, you make living, right? Like you make money, you spend money. You make money, you spend money. Cost of housing's down here, you're never homeless. Cost of housing is up there, you can see you run into problems. And so all of these other factors, substance abuse, mental health, age, disease, what we would call comorbidities, they are interplaying with that fundamental fact, which is the cost of housing. And one of the reasons San Francisco struggles so much is our cost of housing is so high relative to everywhere else. And so you layer on all these other things. So I think getting more data about how to help people through that process and how to most efficiently use the resources we have, that's the mission that's in front of us right now as far as I'm concerned.
And I'll just add a couple points on that. One is, again, we think about this a lot like how a health system would. And so you're right, like there is, just as there is in healthcare, an art and science to healthcare delivery, but again, we're long on art and short on science today. And so we're gonna work towards correcting that balance. And so that means, and that also is true for our providers. We didn't even get into this whole topic, but we know we're gonna have to do this work through service providers, but we can do a better job through the way we do our contracting and procurement and outcomes-based measurement and partnering with our providers to get the right outcomes that people deserve. And to use data to better understand who we're serving. Because Sharky's point's absolutely right around housing and the interplay with the other factors. But there are some folks for whom housing alone is not gonna solve the problem. So just to be really clear, I mean, almost 20% over 25% of our overdoses in San Francisco happen in city-funded permanent supportive housing. That is a huge failure. That is a sign that we are putting someone into a housing situation without the clinical supports that they need to actually get better. So we need to do better, and we need to understand who we're serving, who is that patient in front of us, and to wrap around the right services so they actually get the support they need. And that might mean for some people they actually need less services because it's more an economic situation. So that level of personalization and tailoring, when you meet someone in the ER, you do a clinical assessment up front and you think about what the intervention pathway is through them and what the beds are, and you think about the course of care. We need to do that better up front. So we're, and that will take data, but we're never gonna lose the human element of this. Like, I'm on the streets all the time as a Sharky, as a lot of people who are in this work, because you can't solve this from inside City Hall. This is also a high contact endeavor where you're dealing with people who've been through a lot of trauma, a lot of challenges. Homelessness is a consequence of basically every other system failing. And so we need to recognize that humanity and also try and figure out how do we take this person in front of us and help them get a future that we know they deserve.
Amazing. I think we're good.
All right, let's give a round of applause for David. Manny, Sharky.